Hello and welcome to today's webinar, Boosting Health Through Economic Policy. This is the first of a three-part series on income, wealth, and health in the United States, and we're really excited to have you. The first panelist is Madeline Brown, who is a senior policy associate at the Urban Institute, currently serving a year-long detail as a senior policy advisor within the Office of the Counselor of Racial Equity at the U.S. Treasury Department, and her work focuses on financial security and the racial wealth gap. Welcome, Madeline. Amy Beth Castro, our second panelist, is an associate professor here at Penn at the School of Social Policy and Practice. She is the executive director of the Center for Guaranteed Income Research. This center is a national leader and produces mixed methods expertise in designing and executing empirical guaranteed income studies that work alongside the existing safety net. Welcome, Amy. William Elliott III is our third panelist, a professor of social work and the director of the Joint Doctoral Program in Social Work and Social Science at the University of Michigan. His research is in the fields of college savings account, college debt, and wealth inequality. We're pleased to have you, Willie. And our fourth panelist is Angela Ricciuti, who is a senior fellow and Rose Scholar in poverty studies at the American Enterprise Institute. She studies poverty, the effects of federal safety net programs, and the relationship between labor market outcomes like employment and poverty. We're really glad to have you as well, Angela. So thank you all for being here. Just to set the stage for what we're going to be talking about, one of the strongest and most enduring relationships in public health and social science is the association between income or wealth and health, however you measure health. This association persists across space, it persists across time with some dynamics in how it has changed over time, and it reflects the combination of the causal effect of monetary resources on health, as well as the importance of social structures and other factors that jointly determine material well-being and health outcomes. In recent years, policymakers and academics and business leaders have viewed the income health or wealth health gradients as objects or opportunities to intervene, alleviating both poverty and improving population health. And so today we're going to talk about recent innovations in this space and the implications for policymaking moving forward. So thanks again for being here. Madeline, I'd like to start off with you. So this is a big, interesting space. There's a lot of activity right now. And so can you give us a sense of kind of the key income and wealth building programs over the last 10 years that are being considered, what they are, how big are they currently, and what you think their potential might be to affect health?
Sure. Thanks, Athena, and thank you all so much for having me. It's great to be here today. So as I answer this question, I do want to just make the distinction between income and wealth. I know this is an audience. It's coming from a lot of different spaces, and I think a lot of us feel like we know what income and wealth is, but just for the sake of everybody, when we talk about income, we're talking about money coming from employment, Social Security. This is money coming in and often out of your family balance sheet every month. We talk about wealth, it's assets minus debt, right? So that's anything else that you have maybe in savings, maybe in a home. And that is, again, we measure that in consideration of what you owe to in terms of debt. One thing that I want to just make really clear is that when we talk about financial well-being, and particularly its relation to health and well-being, it's important to think of both of these things as necessary components of sort of financial well-being. And when we talk about wealth, you know, we are also talking about a reality in which half of all households in the U.S. don't have access to $2,000 in non-retirement savings, right? So we're talking about an ecosystem in which 1 in 2 families is having a car payment that they can't pay because they simply don't have the money in the bank. And so I think it's important to just sort of ground us all in some of those nuances, especially because the policies that we're about to talk about do try to target often either income or wealth, or both of them explicitly together, but they are distinct. And so on the income side of things, just in terms of policy, obviously, for a long time, we've had lots of different workforce policies. There's an entire center at the Urban Institute that works on workforce, generally looking at how to get people into higher quality, higher paying jobs, talking about sort of traditional income safety net programs like SNAP, TANF, WIC, tax policies like the Earned Income Tax Credit and the Child Tax Credit, which in the last 10 years, we've seen lots of development on. Now, 31 states plus Puerto Rico and DC have adopted some sort of state earned income tax credit on top of federal But more recently, we've also seen movement in the areas of cash transfers and guaranteed income. And I'll let Amy sort of talk more about some of those details there. She'll be much more familiar. But just in terms of sort of recent trends, people will remember between April 2020 and December 2021, the federal government actually made the biggest cash transfer in the last 10 years, and that was a total of $931 billion to address pandemic-related financial stress in American families. We also saw many localities add on their own public and private dollars to those programs, either to reach extended populations or to add dollar amounts. We've also seen more than 100 guaranteed income pilots emerge since 2018 all over the country. And as we talk about sort of the relationship to health in some of those programs, probably not that surprising to folks on this call, living in poverty is stressful. So studies have shown improvement in mental health. But I also want to just note that, I think it's easy to imagine how health is tied to income for both very poor and very wealthy people, right? But I think what we miss sometimes is that there's actually this gradient, right? So middle-class Americans are healthier than those living in extreme poverty, but they're actually less healthy on average than those living in the upper class. So this is a conversation about everybody. It impacts everybody. Really quickly, I'll just run through some of the wealth policies that we've sort of seen in the last 10 years. And I'm happy to go into more detail on any of this as we talk further today. But talking about things like matched or incentivized savings accounts, which were sort of introduced in the 1990s, including things like child development accounts, and have really expanded since then. Tax policy, obviously things like subsidies for assets, savings accounts like 529s, a mortgage credit tax deduction, things like Medicaid expansion to reduce medical debt. Again, with wealth, we're talking about assets minus debt. So some of the things on the debt side come up. Programs like baby bonds, child development accounts that invest money on behalf of children when they're born, and then reparations that target families from whom wealth was extracted historically. Been fortunate in the last couple of years to work closely with folks like Willie to track progress specifically towards baby bonds and child development accounts. So since 2018, when Pennsylvania became the first state to enact a universal automatic child development policy, there are 7 other states that have universal automatic child development account policies. And then in 2021, we started to see the baby bonds sort of legislative scene pick up. We had Connecticut and DC pass the nation's first baby bonds programs. And then in 2022, California codified a sort of similar program in their budget that year. And 11 additional states since then have introduced some kind of baby bonds legislation. And there are currently 2 federal bills. One that's more of a sort of traditional baby bond, the other one 401 kids, sort of a combination. Happy to talk more about that too, that are currently on the floor. And the relationship to health there, there are studies, empirical studies, a lot of them in the child development account space. Again, that program has been around longer, as Willie can talk about, than baby bonds, but reducing the intensity of maternal depression, improving children's early social and emotional development. So again, we do see these sort of specific behavioral and mental health outcomes in some of these empirical studies, as well as just this sort of longer range, health outcomes across the spectrum. So that is sort of the overview that I'll give us on some of those policy trends.
Madeline, thank you so much. And thanks for this great overview of policies that kind of target labor market, the labor market aspect of it, can include minimum wage and other things like that. Policies that target the economic security piece of it, especially during times of need, unemployment insurance and some of these in-kind transfer programs, policies that directly try to improve the income position, whether it's some type of guaranteed income policy or a tax credit type of policy, and then the policies that address wealth and kind of how those might work over the life cycle. So there's a lot of buckets where there's innovation happening. Willie, I wanted to kind of drill in on one piece of this. So Madeline talked about the income programs that boost income, others that build wealth, and help make that distinction at the beginning. I'd like you to kind of dive in a little more. How are approaches to boosting income, the way we're trying to do that, different than those that would be used to boost wealth? And do you think that those different approaches might affect health differently?
Yeah. So one of the kind of exciting things to me is not only the differences, but we're starting to get to a point to where we're beginning to think about these things and how they can work together to better produce effects, right? And so within a space of like children's savings accounts or child development accounts, these really are, for those who don't know, the same things, different names for the same things. Um, we've seen more recently programs that are looking at combining, for example, children's savings account with a guaranteed income, right? And then looking at health outcomes and other kinds of outcomes with regard to that, and whether or not combining these two things would actually produce better outcomes than they do alone. We've seen something even more recent, at least to my knowledge, is even with children's savings accounts and providing kids with an income. And so, and I think, Amy, you're testing this somewhere as well, which I wish I would have known about earlier, but nonetheless, I think this is an innovative idea. We've also seen within the child savings account space, a lot of times programs have incentives. And what they'll do is if a kid goes to a doctor's appointment or dental health or whatever, they'll receive an incentive and that will go in their account. And so increasingly when the CSA field, the asset field really began, it was a lot about differentiating between income and assets. And so a lot of the early work was to say that, hey, these aren't synonymous, so that they do produce different kinds of effects. And so a lot of the early work was to show how assets alone, for example, could produce things like Madeline talked about, social emotional development effects, parental depression, even parental expectations, kind of more on the psychology side. In Africa, for example, there's been a lot of work done around HIV and different kinds of things like that by Fred Samala. And so you'll find some randomized control trials where these studies have looked at specific health outcomes. Even in Maine, we did some research. We looked at general health outcomes in having a CSA account. And so, but that has been explicitly focused on the potential of assets to produce these kinds of effects. There's a long history and a long body of research on kind of income effects around health and outcomes. And I'm sure Amy's going to talk more specifically about guaranteed income and its effects on mental health and things like that. But to me, what's novel and what's new is just this idea of thinking about how can we, both from an implementation standpoint, a policy standpoint, combine these two programs and might we produce even stronger effects than we see independently? Real quickly, and then I'll stop, is one of the kind of reasons for that is, and I'll give a quick example, is I talk about tangible hope and the idea around tangible hope. And why I talk about that idea is that it helps show that when we think about poverty, poverty is when a poor kid is poor, they're not only income poor, they're also asset poor. And what assets are about is about their future most often, right? Assets allow you to purchase a stake in your future in a way, right? And so they help you think about the future more, plan for the future, do all these kinds of things. And so typically when we think about poverty, we just think about, can they eat? Can they buy clothes? Can they meet some minimal level of goods? But really, someone who grew up in poverty, homeless for periods of times, one of the things that really struck me was that poverty is as much about your future and not having a future, and what that means both to your health and to just to your well-being and how you think about the world. And so that is as important as not being able to eat. I usually give the example of when somebody travels to America, they travel here because of that great hope that someday that if they get here, they'll be able to use their effort and ability to achieve different kinds of outcomes. And they come knowing that it's not going to be easy, right? It's not like the idea is that somehow they're going to get here and this is all going to be given to them. They have to work, but it's a lot better in the environment that they're in because they feel like the institutions, the structures, the things they'll have access to will allow them to dream and not only dream some kind of wishful dream, but a tangible dream that with the institutional help, with the structures that are provided, with the land and richness, I'll be able to achieve what my effort and ability will allow me to achieve. It gives them that kind of sense of tangible hope. And that's an important part of poverty, is not only the ability to eat, but the ability that I will be able to change my future through work and effort with the help of the institutions and resources that society provides. That's a quick answer.
Really, that's a great answer, and I just want to reflect on two things. This idea of tangible hope underscores the fact that a lot of public policies and such as programs that boost income and wealth can work through psychosocial mechanisms that shape aspirations and hopes for the future in ways that shape health behaviors and health outcomes positively. Something that's of great interest to our lab. And there's actually a beautiful paper about this by Debraj Ray, who was writing in the international context about poverty as an aspirations trap, where not having enough goods and services leads to lower aspirations, which sort of fulfills that same state. The second thing I wanted to comment on was this idea of complementarity, is that I think we as economists, even in medicine, we don't really study, which is policies probably work together in ways that can either serve as complements or substitutes. And explicitly testing those relationships to see if there's synergies is something that we can probably all do a better job. And here I think of the work by Rucker Johnson showing the dynamic complementarity between early life investments in education and then school financing later in the life cycle, showing that those two things together produce much greater impacts on college graduation rates than just either one of those policies together. So I really appreciate those remarks on kind of the relationships between programs. So Amy, this is for you. So you're at the cutting edge of this other intervention that's become really, really popular, receiving a lot of attention from different facets of society, and that's guaranteed income. You run this applied research center that we discussed in the introduction that really specializes in cash transfer research, evaluation, piloting design, and all the know-how that goes into doing these trials rigorously and effectively. And I think Madeline mentioned the numerous pilots that have popped up all over the country. So give us a sense about the state of implementation and evaluation today about these guaranteed income programs, and what are we learning from them as far as their health outcomes and health impacts?
Yeah, great. Thanks for having me. And great framing. I echo what Dr. Elliott was saying prior about thinking about complementarity. And so for a long time, it was asset buildings over here, material hardship work over here, and it doesn't make any sense when we put and pull the two together. So I'm just thrilled that we're having this conversation today. Thanks for having me. So to set the stage, I just want to talk a little bit about terms, similar to the way that Madeline did. So when we think about guaranteed income, it sits underneath this broader umbrella sort of suite of unconditional cash. So unlike the traditional safety net, you don't have to do anything in order to receive it. You don't have to perform a particular behavior deemed deserving, by policymakers. The logic behind it is that you matter because you're human. So you're receiving the funds either way. So within that bucket of unconditional cash, there's broadly three different terms that you'll hear. And unfortunately, if you're following it in the press, they tend to get conflated, which is why I always start with some definitions. So the first term you'll often hear is basic income. Basic income is unconditional, it's recurring, and it's enough to cover one's basic needs. And sometimes that might apply to a small geographic area or a large one, but that's kind of a separate category. Then there's universal basic income, which is exactly what it sounds like. That was the sort of the anchor in Yang's platform a few years ago, which is why it sort of became part of popular parlance, we'll say. And it's exactly what it sounds like. It's universal. It's supposed to go to every single person in a given city, state, country, what have you. But key, similar to basic income, it's supposed to be enough to cover your basic needs. And there's a universality kind of element to it. We have not had any UBI experiments here in the United States. The closest you could come would maybe be the expanded child tax credit, but that just depends on your definition. And the third category is what we're studying, which is guaranteed income. It's a recurring amount of cash. Like the first two, it's also unconditional. It is not enough to live off of. You typically receive it on a debit card or some sort of a fintech app. And the idea is that it's recurring. And so the logic behind guaranteed income here in the United States from a research perspective really rests deeply on a theory of change that comes out of public health that is anchored in sort of the concept of income volatility. So, we know that income volatility, when you're experiencing that consistently, meaning your income is going up and down each month or, quarterly throughout the year, that unpredictability, of course, we know what that does in the market. You're read as a poor bet, right, by lenders. But when we think about it through a health lens, those inequalities actually show up under the skin. So that unpredictability, leads to mental distress. It leads to a sort of uneven health behaviors in many cases. And it really sort of can function as an upstream determinant of poor health. So sort of the theory is that if you're smoothing that income volatility over time, what type of capacity might you unlock in terms of human potential for goal setting, goal setting, of course, across a range of things. But when we're thinking specifically about health, it comes down to stability, and the way, like, sort of, how to put this, giving people a floor that they're able to jump off of in order to plan for the future, right? So if we look at lump sum payments, things like the CARES Act, Earned Income Tax Credit, Alaska Dividend Fund, casino dividend payments, those are lump sum payments. And we know that they relieve material hardship, but we haven't seen any changes on health or well-being with lump sum payments. I mean, it really takes a minimum of 6 months of payments to calm income volatility long enough that you start to see sort of the seeds of change in somebody's well-being or in the body. And so there's a big distinction between recurring versus lump sum. So that's sort of kind of where we're at in terms of theory of change in the literature. And then as far as what we know so far, it's really mixed. I have to be honest with you. It's mixed because a lot of the data on these pilots a lot of the data is coming from pilots that were started during the pandemic. So you're talking about samples who were largely women, low-income women who have kids in the home, where they are experiencing the worst that capitalism has to offer in the middle of a global public health crisis, right? So their starting point was a little bit below what you're going to see in some of the other experiments that have data pre-pandemic. So for instance, Stockton, which is the project we're probably best known for in the country, our first year of data pre-pandemic, happened before the pandemic. So we do have one solid year of data there that shows us the possibilities as to what we can see. And what we saw in that particular study was after 1 year of unconditional cash payments, reductions clinically and anxiety and depression in the treatment condition. The control group did not have any change, or they maintained sort of in the status of likely to have a mild mental health disorder. And so we're not talking about sort of, more serious, persistent psychiatric conditions or health conditions, but those everyday stressors that are tied to the fact that you cannot pay your bills, and that unpredictability really shows up in people's well-being. Fast forward to the pandemic, some of the findings that we've seen on health that have been really promising have been increases in food security, increases in health behaviors. And really, I think the crux of the question, and we'll probably get into this a little bit more as we go, but really comes down to time scarcity. What we've seen time and again in these experiments, we're currently running 38 experiments with common methodology. We have about 20,000 people in treatment and control. And one of the things that we're seeing over and over again is that time scarcity is linked to financial scarcity, is that the two things are tied together. And one of the things that we just published this summer out of Los Angeles was the fact that once people had that income volatility calmed and they had more space in terms of time, they allocated it towards health behaviors in ways that we didn't expect to see. So I don't know about you, but if I suddenly had an infusion of time, I don't know that I would suddenly be prioritizing preventative health. But if you think about families that are low income, and in that particular sample, we're talking about an average income of $14,000 a year, their bodies are their life insurance policy. And they know that. When you are the strongest member of a financially fragile network, you are holding together the health and well-being of an entire family. And so what we're starting to learn is that people are brilliant in the ways that they reallocate the time that they receive through guaranteed income experiments and then redirect it towards their health and well-being. So we've seen things like increases in treatment compliance, resuming PT, exercising more, people are reporting better sleep. And then most importantly, if you're thinking about it through the lens of children, more predictability in their scheduling at home. So there's sort of a range of different things that we could talk about, but that's just to give a broad overview as to where we're at right now. And then the last thing I'll say in this, and I'm sure we'll ask questions about this later as well, is that these programs and experiments are designed to work alongside the safety net. So we're not looking to replace the safety net, we're looking to work in tandem with it. And so we protect benefits where we can, but it's not always possible to do so. So sort of the big kind of black box right now in the research space around this is that we're collecting data by and large on populations where we can protect benefits. So there's some really open, important questions to ask about clinical trials when you can't protect SSI. So I'll leave a pin in that for later, but I think when we're talking about health and unconditional cash, we can't talk about it without thinking about the safety net and the ways in which we can potentially push people further into poverty or cause them to lose a benefit that's going to cause problems down the line.
Thank you so much, Amy. That's fantastic. And I mean, there's a lot of rich material in what you just said, and a lot to chew on. One of the things I just wanted to hone in on was We often think about, we're talking about income programs to improve population health, but the economist question might be, what is the broader welfare implications? Like, are people better off in that general utility sense? And you've highlighted a number of dimensions that I think, we may not think about in the health space, which is people's cognitive bandwidth constraints, the time that they have available for various activities that are utility enhancing, the enjoyment they may get from those activities as a result of having being able to smooth their consumption in predictable ways. And so these are all things that I think are important for welfare that we may not be thinking about as a health community, but certainly as we evaluate these programs and try to understand their returns, we may want to keep in mind. So we've heard a lot about different types of programs that can potentially intervene on income and wealth and what they might be able to do for population health. And so, Angela, I'd like to turn to you just to give us a sense of, we've talked about benefits a little bit, but what are some potential downsides of income and wealth programs of the various types that we've discussed? I know in the past, you've discussed potential disincentive effects on labor supply and employment, as well as other matters that might be unintended consequences of programs like this. So would love to hear your thoughts on those concerns and the evidence for those concerns.
Yeah, sure. And thank you for having me. I feel like, there's a lot to unpack. So maybe I'll just kind of make a few points. So, I mean, I think we all can agree, income is better. It results in, more income is better. It results in better outcomes for kids, certainly health related, and a variety of outcomes. I think where the questions come in for me and, kind of in the field is, can you design government programs that increase income in a causal way then that leads to those better outcomes? And I think that's where the evidence is a little bit less clear about that causal relationship. And to me, that's really the crucial kind of question, because there's obviously a lot of reasons that households or families have low income, and just sending more income to that household doesn't necessarily solve those issues. And so if it's those underlying issues that are actually causing the bad outcomes, then those programs will not be necessarily effective. That raises another question, though, is, well, maybe those programs could be effective in the short term. To Amy's point about income volatility, can certainly have some short-term benefits for households, meeting immediate material needs. I think we can also all agree that that's, a good thing. But then to the question about potential downsides, I think we also need to think about these longer term issues. And if the programs that are being provided are not designed in a way that's addressing those underlying causes, it can potentially then lead to worse longer term outcomes. So everybody's familiar with the debates over employment disincentives for unconditional cash programs, for example. And the evidence is, largely mixed. It certainly depends on the methods used to study these programs, and then the design of the programs, and then the time period you're looking at. We can all pick apart that literature for sure. But I don't think that underestimates the bigger issue is that we should be concerned about some of these downsides, because if transferring more income to households leads to less employment, for example, those households would not benefit from all the non-financial benefits to employment, including, better health, that the literature shows employment leads to better health. So I think those are certainly concerns that we need to be aware of. And all of those are kind of at the individual level. I think another area and potential downside that we don't talk a whole lot about is kind of the more macro level. The types of programs, the size of payments that would need to go to households to result in really meaningful improvements, they would need to be fairly large payments, and that has a tremendous cost. And we have to be aware of where those costs, how those costs are covered, and the perhaps unintended consequences of covering those costs. Meaning, if we have to increase taxes, for example, to cover to fund those programs, there's obviously macroeconomic implications for that. And there's actually a group of sociologists out of Belgium, I believe, that kind of did a paper that looked at those more long-term kind of macroeconomic effects. And their take was that there might not be the return that I think a lot of people would expect when you compare the outcomes associated with some of these programs to those kind of larger societal effects that would be required to support those programs. So again, kind of individual level, macro level, there's certainly downsides to some of these programs, and we have to kind of consider both and balance them out and see which one is more convincing and which one serves kind of the broader good.
Thank you so much for that, for setting the stage about what the different drawbacks might be and just kind of the considerations that are needed to design programs going forward in the future. And so that's actually a question I wanted to put to the group, just kind of following off of this. And I think really all of the answers that we've had so far. So based on the research that's out there, whether it's cross-country type of comparisons or research from the United States, how would we make these programs most effective so that the rate of return or the cost effectiveness of those programs is higher than it would otherwise be. And that could be, let's just say for the purposes of discussion, we're thinking about sustained improvements in health. So what would you do to make these programs work better? It can be about the size of the benefits. It can be about how it's targeted or not. How would you think about what would an ideal type of program that supports income and wealth would be from your perspective? And we can go back around the horn, or if one of you want to jump in and take the question, we can start there.
I guess I could jump in. I would say that particularly with regard, I'm more familiar with kind of return on investment for the asset programs. And we can look at even something like the Homestead Act or the GI Bill. And like the return on investment in the GI Bill is like 7-fold according to Congressional Office. So, I mean, with regard to the children's savings account programs and that we have seen, there's actually, and they're not released yet, so I can just tell you there is, but they'll be released soon. They're doing a series of return on investments in these kinds of programs across several of the major states. In the return on investment, it's strong in each one of those cases. In using randomized control trial data to base these off of. So this is the history in the US when we've made these kinds of investments, typically, they can be strong. So some of the things we can do to ensure those investments are used, because obviously you can find examples where the investments haven't been as good or done right. I think you need to make an ample size investment, right? One that we think will work and not underinvest. Too often we underinvest and get a lower return in the end because it was never enough money to actually help the poor get to where they get. And we know this. We know this in the beginning of kind of how much it needs to take, and politics will help us water it down. And we each get a victory, but we produce a program that will never work in the first place. So don't do that. Sometimes underinvesting is the worst way to go. Secondly, make sure that we have an institutional structure that will allow us to implement and deliver it. Amy talks about this quite a bit, is the importance of implementation. We talk about it within our own field, and we are learning and have learned a lot about how to implement these programs in a cost-effective way that produces the benefits and that will allow for not only the federal investment, and I'll be mindful of time and cut this off here, but not only the federal investment, but I talk about things like having infrastructure that allows for multiple streams of assets to flow into an account, right? And there's ways of doing that preserves equity for low-income people by having caps on higher income people, how they can benefit from it. But allowing it to not just be, okay, the federal government donates whatever, it puts whatever amount of money in that account, but let's think about how the community, how the individual, how others, how foundations and stuff have an infrastructure in place that allows for all those assets to flow into it so you can really maximize the money being provided by the federal government and others.
Yeah, I think those are great points. I would just add, and I think this speaks to really something that we've all talked about here. I think the the reliability and the sustainability of these programs has to be there for us to see return on investment. I think families need to know that they can really count on this money, whether it's an income or a wealth building program, like they need to believe that they're going to see these dollars at the end of the day. And I think that only comes from what Whitley is saying is like large investments, like really putting our money where our mouth is, and also setting up the infrastructure that creates that sustainability. So in the wealth building side of things, we talk about universality and automatic enrollment, and then progressive from there, right? So everybody gets an account. It cleans up a lot of the administrative challenges of trying to find target populations. Everybody's enrolled. In a lot of these cases, everybody gets a seed amount of something. And then from there, or in that seed amount, you're building progressivity in either by income or by family wealth if you can, so that you're seeing some of those equity considerations be made, but you're doing that investment again in a way that is large enough that people will actually meaningfully change their life circumstance, right? But also you're setting up the infrastructure that helps people believe in the sustainability of this kind of program. And one thing I'll just note on the wealth building side of things is that we've seen these sort of early, especially in the child development account space, these early impacts on parental expectations, like this idea of this money is sitting in an account for my child. And even though I can't touch it till they're 18, it's already changing the way that I'm thinking about their future and my future. And because we can work with that kind of timeline, just from like a pure numbers standpoint, it does mean that we can reap the benefits of a market here, right? We saw in Connecticut in their baby bonds program, the initial sort of funding scheme they had was 50 million a year in annual appropriations for 6 years. And then they came into a bit of a windfall one year because of a sort of tax detail that I don't need to get into. And they realized that they could actually allocate $381 million 1 year, and it would fund the same cohort of 12 years of kids. So, and that they were able to do that again because they're working with an 18-year time horizon, and they can think about the market returns in, medium, low, and high risk situations and behave accordingly. So I just think as we think about sort of combining these programs, if you can set up good, solid infrastructure and use the timelines that you have, the calculations of the ROI of the investment change because the actual size of the investment can be reduced.
Amy, go ahead.
Yeah, did you want to jump to the next question, Athene, or you want me to jump in on this one?
Yeah, no, jump in on this one. That would be great.
Yeah.
And
Okay.
yeah, the other thing that if we can add to that, in discussing this question in the audience, David Hall mentioned if we need larger amounts of resources being delivered, would there be general equilibrium effects that we need to think about in communities as a result of this influx of cash? And that could be positive or negative, but just something perhaps we can add to the answer as we go through this question.
Yeah, yeah, no, gotcha. So thinking about sort of to the original one of sort of what would make them better. You've asked this of somebody who's running a lot of experiments. I could spend 45 minutes, but I won't. I'll just give a couple. So, the first I would say is common instrumentation. So, one of the things when we were first, starting to do this work across the country on guaranteed income is that, I could count on one hand the number of PIs that there were. So we could just sort of really easily collaborate behind the scenes and use sort of common methodology to make sure that our data were speaking to one another. And now as the space has grown, there's tremendous variability at times in the way that people are measuring outcomes, particularly around health. And so, quick plug for pre-analysis plans and registered clinical trials, please read the measures that other folks are doing. Most people are sort of that are working with us or working with Apt Associates, where a lot of our, secondary projects are located. We're using common measures that are validated instruments, and so I would really caution folks against doing things like designing their own scales, designing their own question. There's a place for that, but not yet is what I would say is that we have really, incredible resources at our disposal in terms of measurement, and we ought to use those so that our findings we're building a body of evidence where we can speak to each other. I think that's really key. And then the second thing, I mentioned this in my prior comment, but I'll just say it 100 times more, is that we have to find a way to protect benefits at scale. We're hoping that guidance will eventually come down federally, but it's the number one block towards really exploding the cash space when it comes to like understanding health impacts, right? Is that just to even target certain populations, we cannot do because we would risk people losing their benefits, and we just cannot do that. So that's the number one thing. And on the one hand, that's an advocacy issue. It's a policy advocacy issue, but it's also an issue for experimentalists. And it's probably the number one thing that's holding back the science right now. So I don't know what you do with that per se. There's only so much I can say publicly. There's a lot of work happening behind the scenes, but I think being really smart about benefits protection and knowing exactly who we're targeting. That leads to sort of the third thing is really trying to figure out dosage and duration. So we're really looking to see what amount of money over what period of time creates change on different health outcomes. We actually don't know that yet. We're getting there. But we started at $500 a month in Stockton because we know that $400 threshold is the thing that often tumbles people into poverty if they can't absorb an unexpected $400 expense. Well, $500 doesn't go as far anymore with inflation. So we really don't know, especially in some of these experiments that we started in 2020 or 2021, the amount of money that we set for the treatment group, it doesn't exactly hold in the same way that it did prior. So I'm really kind of holding out hope that we will have some longer experiments outside of the scope of the pandemic in a more normative economic time, if I could use that term loosely, in order to get at some of those questions.
Thank you, Angela.
Yeah, I'll just add, and I'm thinking about this kind of more of a broader policy, coming at it from a broader policy perspective, and maybe in a way that actually suggests that guaranteed income programs are not the way to go. But if we're thinking about how to design programs, I mean, policies, we kind of know what works. Policies that do not undermine employment, do not undermine two-parent families, and do not undermine human capital development. So, and we know that even work by Opportunity Insights, Raj Chetty team at Harvard, they're not looking at health outcomes per se, although they look at that a little bit. They're looking at mobility, so not even poverty reduction, really mobility over time. But I mean, their two kind of primary drivers were neighborhoods that had, so the better mobility happened in neighborhoods that were characterized by higher two-parent families and more employment in the neighborhoods. So we kind of know that those are the key things. And so our policies need to reflect that. So to the extent that we look at policies that have been the most effective, I mean, it's been the earned income tax credit. It's tied to employment. We know policies that are not tied to employment, like aid to families with dependent children, the pre-welfare reform cash welfare program was not good for families and did not result in better outcomes for kids. So it's kind of those key things that I think we have to keep in mind as we're designing these programs. And even if we're not encouraging them necessarily like the earned income tax credit does, we certainly don't want to be undermining them.
Willie, you had your hand up?
Yeah, I do appreciate that, because I believe in work and that people should have to work and so forth. And there's evidence that work is important. We do have to recognize at some level that a lot of people are forced to work multiple jobs because the jobs they're working doesn't pay enough. It gets into the time issues, which gets into, and there's research on this, that these can have negative effects. So it's not like employment is the be all get all of all things. I think we would all agree that we don't want these programs to keep people from working, but there is importance to people, low income people, being able to invest in their growth and development, and sometimes step back from work to get a better job so they can go to school, so that they can develop their human capital, so they can get a better job that pays a living wage and that pays these kinds of things. And so it's not as simple as simply saying simply work is needed, but the kind of work and it does matter. And so I just think we have to have a more nuanced conversation about that. Again, I'm not arguing that people, and I don't even think there's strong evidence, as we said earlier, it's very mixed evidence to whether or not these programs even keep people from working or reduce working. And so we can't even make that statement as of yet because the evidence is mixed.
On that, there's a well, since we're talking about work, Maurice Goodman has a question about complementarities, getting back to something we had talked about earlier. And they ask, is there a policy space where you can marry workforce development, so job training, skills training, to limited guaranteed income, where there's an opportunity to secure the floor for people who are struggling but also looking to kind of progress in employment and find jobs. And the second question is, as part of this, are there employer tax incentives to help higher flow? So here is getting at this idea that is there the possibility, has this been tried where people have married these kind of workforce programs? I know Larry Katz and others studied job reskilling programs recently. It's kind of the new take on job training programs and find that those types of reskilling programs are successful in placing people in higher employment. Do you see the potential for complementarities between those programs and the types of income and wealth support programs we're talking about now? And has that been tried somewhere? Amy, you might know through some of the
Yeah.
things you're doing.
I just have to say, I don't know who asked that question, but I love it. Thank you so much for raising it. The short answer is no, it hasn't been tried. But it's such an obvious one, it drives me bonkers. So one thing that I will say when we look at sort of, and I should say, keep in mind, guaranteed income is an individual intervention. It is not a macroeconomic structural intervention. So what we're talking about are the way that individuals react to local employment markets. And one of the things that we've seen over and over again is that it's not, the categories are so messy, right? So it's not as though this person's full-time and this person's part-time. It's more of a question of this person might have full-time employment plus working for Uber. This person over here might have 3 different gigs that causes their schedules to be completely unpredictable. And oftentimes what we've noticed is that when people don't have what we would say in the social sciences, a quote unquote good job, a predictable job with benefits, they're usually trying to pick up those skills along the way. So one of the things that we've seen across a number of our sites is slight increases in full-time employment. And what's happening there is not that people are enrolling in a guaranteed income program and then just magically changing careers. That's not how the market works, and it's not how people work. But instead, what they're often doing is they're using the GI to leverage skills that they had prior or to complete things that they had started and never were able to finish. So, I mean, these are things that we see over and over and over again, where people have, let's say, an unpaid internship that might be a month long. Well, if you're living paycheck to paycheck, you can't take a day off of work to apply for a job that might lead to an eviction if you're missing a paycheck, right? Let alone do an unpaid internship or even just manage the childcare issues. And so thinking really creatively about the ways in which a short-term guaranteed income program can function within a workforce development program is a natural next step to see some of the places that we need to go. I think it's pretty exciting as far as a prospect, but nobody's done it yet. But the question is definitely picking up on something that many of us who do this work really hope will happen. Because we see, again, they use that money to leverage other things that are around them. The last thing I'll say on this is, again, in LA, what we noticed was that it bought people time, particularly young parents. So they were able to sort of take the cash, reduce their number of hours in gig employment to find jobs that were closer to home, that were more conducive to parenting. So things like that. It's not about sort of having that program in perpetuity per se, but using it in such a way that you're then able to leverage other opportunities and invest in yourself the way that Dr. Elliott was mentioning.
Thanks, Amy. I think Angela wanted to weigh in. Just quickly on that, Angela, before you weigh in, there's a paper in the journal Labor Economics that looks at minimum wage increases and basically employment seeking among marginalized populations, showing that when that wage floor is increased, it effectively allows people to pay the cost of searching for jobs that are at a farther distance away. And we know from Opportunity Insights, people are very, very local. So these types of policies potentially can lower search costs for employment opportunities that may not be obvious in the local context. Angela, you were going to jump in.
Just quickly, so this is a different context, but that marrying of workforce development with it's not guaranteed income programs, but we certainly have that within TANF and we have that within SNAP. And I spent about 15 years working in New York City's TANF program. So the workforce development component is, it's there. What we find in those contexts is they're not very effective. Much of it is because participants, there's a lack of participation, whether because there's stressors in the household that prevents that participation, or the services are not viewed as beneficial to participants. For whatever reason, they're not very effective. And so I think that there's opportunity there to do that, but we should just recognize that, that system, workforce development, has not been overly effective in kind of at scale for the most part. And just to the last point that was just made, I believe it's the Gary research, but it was in Texas and Illinois. They had some papers that came out over the summer, but that did look at this issue of kind of did people with the that were in the treatment group get better quality jobs because it gave them the opportunity to wait to find those jobs. And if I remember right, I think they did not find that, and they didn't really find any support for that. So I think it maybe is a little bit more nuanced than seems obvious.
Angela, I'm glad you brought that up because this brings us to Sumit Agarwal's question about, well, he actually mentions the Sarah Miller et al. Study funded by Y Combinator that I think looked at this particular question. This is the Texas and Illinois study. But this question is kind of thinking about the nuance in a different way, which is, he says, cash transfers have different, even oppositely signed effects based on context and targeted populations. And I would say, whether that's cash transfers or any of these other programs, I think there's heterogeneity. The study that you mentioned found that cash leads to more ED visits in Illinois and Texas. And then Chelsea Eats, which is a study that he has led, found that cash leads to fewer ED visits in Massachusetts. So just thinking across the country, context shapes behavior. Contexts are local. People are tied to their local communities. And so we may not expect the same programs to generalize. But how do we think about that? How do we reconcile? How do we understand when certain programs are going to have certain effects and when they may not? And this is for everybody.
I'll jump in. It's such a good question. I mean, it's something that we're constantly hammering on, and this is I'll go again back to common instrumentation. So this is part of the reason why we're using, by and large, the same measures in every single location. There's obviously things that we're adding to, but there's core instrumentation that we're using. The reason being is that things vary with policy subsystem. There's different cost of living. There are different sort of supports in place for things like paid family leave. Can you afford childcare? Can you not? I mean, there's going to be tremendous variability, and a lot of that comes down to rootedness in context. And again, we just don't know. I mean, unfortunately, a broad brush of, I'll go back again. I hearkened to Yang, a little bit ago at the beginning of the call. This is why, we're not necessarily in favor of things like saying, just give everybody in America $1,000 a month, just flat. That'll just fix it, right? $1,000 a month might make sense in one city, but not another. And we just simply don't know. So having, those questions rooted in context really matters. And understanding that different subpopulations are going to react to unconditional cash in different ways. The key thing that we do know from running so many of these experiments, even though many of them are still underway, is that people plan based on what you tell them. So when you tell folks you're going to get this amount of money for this period of time, they by and large sort of tailor their behavior and their planning around that messaging. The things where we see things really go awry are when it's, well, we're going to give you this money, but then we're going to take it back, right? That's mimicking the unpredictability of the current safety net and the benefits cliff when you have no idea if you're about to lose SNAP or you're about to lose your housing voucher, right? We're creating more volatility when we function with our programs in that way. And so being really clear at the outset, this is how long you're going to get the money. This is exactly what it's going to be. People tend to react to that information. And that's the exact opposite of the way the safety net typically functions, which is completely variable and tied with a lot of administrative burdens.
Yeah, I would just underscore this piece about sort of policy landscape. I think especially as we are consumers of research and consumers of evaluations of these pilots, understanding local policy context is so important. And I would just implore us all as researchers to try to provide that in these papers as much as we can. Like my first question with this Texas-Massachusetts split is like, well, is this a Medicaid issue, right? Texas hasn't expanded. So are people taking this cash and going to the emergency room because they don't have insurance? Whereas in Massachusetts, they do, so they don't need to use the cash. Like there's just all these secondary questions that I think speak to the nuance Amy is talking about. And I just would make one more point on this nuance because I see this question in the chat and this conversation around two-parent privilege. It's another space where I think we really do need to have nuance in this conversation and make sure that we're understanding causal directions. But, we at Urban, I can give an example. We've done some work in our tax space where we found that when you control for income, penalties are more frequent and larger for Black couples than white couples, right? So all this conversation about like two-parent household, let's make sure that people are married and having their kids. And then we also have studies that show that actually now we have a tax system that's penalizing people differently, even when you have two-parent households. So I don't think that we could, underscore enough that we have systems that do not treat people equally in this country. And I think understanding that nuance and especially as we interpret some of these study results, is so important.
I like to bring up, I'm saying I'm gonna bring something up, but I'm really tossing it back to Dr. Castro because I've heard her talk about this, and maybe this is useful, that she talk a little bit more about it. And that is that even with these guaranteed income pilots, I mean, they're pilots, right? So they're not like having a policy that extends forever. I believe you've talked about in the past, that when these programs are winding down, it can change effects as well. And so some of these things that we're seeing might just be kind of the duration of these programs, and it might need to be longer in extent because a lot of them run a year, 2 years, or whatever. And so I don't know if you could speak a little bit about that. That'd be good, I think.
Yeah, thank you for bringing that up. I mean, you're right. There's been exactly one experiment, that's it, in the United States that has run 3 years in length. That's sort of a general sample. And that's the open research study. That's, and those again restricted to people between the ages of 20 and 40, right? So if you know the weathering literature, the average onset of detectability for things that Geronimus's work is capturing is the age 37, right? That's all we've got. We have babies first years, but that's a little bit of a different project and what it's looking at. And so by and large, what we're talking about here are short-term, very short-term infusions of cash in some cases. And we really don't know yet what happens, over longer pilots, 3 years, 4 years, 5 years. But what I can say is that the early signals are pretty promising, but it's really an open question as to, how might behavior change or goals may shift. If it's 3 years long versus 4 versus 5, we really don't know. I mean, hopefully we'll be able to speak to this in the coming years. We are looking at administrative data in a number of our sites. So we want to be able to ask these questions comparatively to that question that came prior. Well, why would we see, increases in ED in one state or decreases in the other, right? Well, sometimes it's going to come down to local policy context, but it also might come down to duration of treatment. And it's a question we can't answer yet, but we'll be able to in the future.
Just real quick, and I think that has something to, when we thinking about the employment effects and whether people, if I'm investing myself, taking this money and grow, it might take longer to see the fruit of that than it does a year, 6 months, 2 years to actually see that come to pass.
Yeah, exactly. And I mean, just to go back to open research again, I think one of the things that's so interesting is that they saw a reduction in work by 1.3 to 1.4 hours a week. And some people were running around with their hair on fire that's a bad thing. I'm like, are you kidding me? Americans work way too much to the detriment of our health, and especially for low-income people. If low-income people start working 1.3 to 1.4 less hours a week, that's a good thing, right? Because we know that time scarcity and unpredictable work hours lead to poor social determinants of health. That's so established in the literature, right? But that's the only study we have thus far showing that. And just practically speaking, you can't live off of $1,000 a month or $500 a month. It's just not possible, right? So there's some real open questions that we can't answer yet. But yeah, the timing and duration comes down to everything.
That is wonderful. I know we had a wrap-up question that we were going to ask, which was, what is one policy change that would most advance this field? I think we have a minute. So if you can quickly say, like in a sentence, what would you like to see to kind of help us move forward in this policy space? I think we've hit a lot of it. What would that be? What would you want to know? What would you like to see? We can just start from the beginning, Madeline.
I would love to see a federal, universal, and automatic early life wealth building program that's progressive. I would also like for us to continue getting our private sector partners in these conversations. There's a lot of little p policy that employers could do tomorrow to improve the livelihoods and job quality of a lot of the employees in this country.
Fantastic. Willie.
I think it aligns with what Madeline said, but I would like to see infrastructure put in place along with money in those accounts so that we could both do wealth building and kind of income type programs combined together.
And Amy?
I would love to see some experimentation where you're able to fully protect SSI and fully protect Section 8. We know that lack of affordable housing is one of the key drivers for poverty and for poor health. And that's a benefit that's almost impossible to protect at this point in time. So we're really being held back on implementation data, which that's the key, right? We can design the perfect study as researchers, but if we can't actually implement it in the messiness of the human experience, we're just kind of working off of conjecture and ideology. So I would love to see us move forward in that way.
Thank you. Angela.
I guess I would just like to see attention shifted to things we know are effective, like the earned income tax credit, school choice, things that we know are going to have long-term outcomes, positive outcomes.
Wonderful. So Madeline, Willie, Amy, Angela, thank you so much for joining us. Thank you to the audience for joining us and for your questions. This has been a really fascinating discussion, and I've learned a ton. And certainly it's going to inform my research and reading going forward. Just wanted to say to the audience, save the date for our next event for LDI. It's Advancing Value-Based Care in Community Health Centers, which will take place on November 8th via Zoom. It'll be moderated by Dr. Paula Chatterjee. Visit ldi.upenn.edu for more information, and then look for a transcript and recording of this webinar sometime in the coming weeks. Thanks again for coming, and have a good day.